Hi everyone, thank you very much for this very kind invitation. Unfortunately, I'll not be able to be with you today, but let's start this presentation. So, my name is Monica Andersen. I am professor at the Federal University and director of the Sleep Institute. Today, I'm going to cover several topics related to sleep disordered breathing, including definition, prevalence, and risk factors, especially related to gender differences, mainly cover women. My presentation will also focus on different sleep patterns, diagnosis, type of treatment, and adherence to treatment, the role of sex hormones, and my final considerations. So first, we have to have an idea of sleep being different between men and women. There are very few studies covering this topic, but mainly men are reported to have more N1 of non-REM sleep, more arousals, or also more complaints of daytime somnolence. Regarding women, more time spending in N3 or slow wave sleep have been described and more complaints of insomnia. According to the latest international classification of sleep disorders, it's possible to classify sleep disordered breathing into OSA or obstructive sleep apnea, central sleep apnea, as well as sleep-related hyperventilation and hypoxemia, and finally upper airway resistance syndrome, defined by Christian Guilleminot in the late 60s, 70s, among others. It has been reported that the prevalence of sleep apnea is 9 up to 38% and is more common in men than in women. In contrast to sleep apnea, in which continuous respiratory efforts are observed, central apnea is defined by the absence of respiratory effort during airflow interruptions, occurring in less than 1% of the individuals without association with other comorbidities. Regarding upper resistance syndrome, recent studies have shown a prevalence of 3.1%. This upper airway resistance syndrome was designated to delineate a group of individuals who do not meet criteria for obstructive sleep apnea, and the prevalence of this disorder among the different sexes remain unknown. The prevalence of hyperventilation hypoxemia is still not clear, but the frequency of obesity hyperventilation syndrome is around 8 up to 20%. As previously presented in other opportunities, we know that sleep apnea stands out among other sleep disorders. From now on, I will more focus in my talk particularly in obstructive sleep apnea. Using the Sleep Institute infrastructure, we have conducted 4 editions of epidemiological study called Episono. These editions have happened in 87, 95, 2007, and 2015. And finally, in 2018, we conducted another edition. This project covered over 1,000 participants from 20 up to 80 years old, and during all these editions, all participants completed one full night of polysomnography, completed questionnaires, and other tests. It has to be mentioned here that obstructive sleep apnea has occurred in 32.9% of the total amount of participants. And it has been seen that 40.6% of men were diagnosed with sleep apnea, while in women it was 26.1%, which confirmed that men are more affected by sleep apnea than women. In a recent study also published by our group, considering the diagnostic criteria for upper air resistance syndrome to be a apnea-hypopnea index lower than 5 events per hour, minimum saturation of 92%, the prevalence of airflow limitation during sleep for less than 5% of the total sleep time, and daytime symptoms, we have found the prevalence of the condition of 3.1 as an average, in while we have 4.4 in women and 1.5 in men. Upper wear resistance syndrome is more prevalent among non-obese women and decreases with advanced age, as can be seen in this table. This article showed here discusses the spectrum of sleep disorder briefing and demonstrated that upper air resistance syndrome can be a symptom that precedes obstructive sleep apnea. It has been reported that is one of the first signs observed in persons who start snoring regularly or occasionally. Sleep disorder briefing occurs in 24% of young middle-aged men and 9% of women, with a male to female ratio estimated between 3.1 and 5.1 in general population. Sleep disorder briefing occur in 70% of older men and 56% in older women. The main risk factors in both sexes are obesity, age, anatomical factors, hormonal factors, alcohol intake, smoking, medical conditions, and use of sedatives. Some of these risk factors end up being more prevalent in men, such as alcohol consumption, and women hormonal factors. Intrinsic and extrinsic factors impact women's sleep differently from men. Women typically report poor quality and more disrupted sleep across various stages of life. Findings from clinical and basic research studies strongly implicate a role of sex steroids in sleep modulation. After the first menstruation or period, several changes are observed that distinguish female and male sleep, included increased EEG activity and frequency of sleep spindles in non-REM sleep in females. In women, the presence of sleep apnea appeared to be directly associated with obesity and also age. Postmenopausal women without hormonal therapy had a significantly higher prevalence of sleep apnea than the presence of the premenopausal women with hormonal therapy, 2.7 versus 0.6%. As most of you know, sleep patterns tend to change as one ages, and that is also true for females. Of note, female sleep is deeply influenced by hormonal changes across a woman's life. Pregnancy and reproductive years are risk factors for sleep apnea or the sleep disorder briefing in women. Morphologically changes can occur during pregnancy, enhances the onset of sleep apnea or sleep disorder briefing in general, such as compression of the diaphragm by the fetus and the reduction of lung compliance and muscle efficiency associated with lung expansion, especially during sleep. It is accepted that obstructive sleep apnea is more prevalent in men compared to women, with the women being protected for obstructive sleep apnea associated with dysfunction during the premenopause phase. This female protection is based on the upper airway mechanical differences inflammatory and oxidative stress protection, and higher levels of sex hormones such as estradiol and progesterone. With age, the prevalence of obstructive sleep apnea increases in both men and women. The higher prevalence of obstructive sleep apnea in men is also associated with their higher susceptibility for insulin resistance and beta cell dysfunction, and the higher visceral deposition of fat in men instead of the higher subcutaneous deposition of adipose tissue in women. In this study, we aim to investigate different measures and their effectiveness as a screening method for diagnosing obstructive sleep apnea in each sex. We also evaluated which measures are associated with obstructive sleep apnea in a large population of São Paulo. 552 women and 450 men were submitted to polysomnography and anthropometric measures as body mass index, waist to hip ratio, and neck and waist circumference were collected. The variables were then compared between men and women. Regarding the anthropometric measures, men and women were significantly different in relation to variables of neck and hip circumferences. Likewise, all obstructive sleep apnea variables were also different between them. This another study reviewed the importance of anthropometric measures of parameters related to sleep apnea in men and women, the accuracy of variables and the best variables to predict obstructive sleep apnea was different between genders. In the male population, a waist circumference of 92.5 centimeters corresponds to 72.9% accuracy in rating mild, moderate, severe obstructive sleep apnea. In women, a waist circumference of 95 centimeters corresponds to 78.9% accuracy in rating obstructive sleep apnea, regardless of severity. In men, when considering only moderate severe apnea, a 0.61 waist to hip ratio represents a higher accuracy, 78.4%. Meanwhile, in women, 0.7 waist to hip ratio resulted in 88.2% accuracy between the genders. Lastly, an analysis of all these individuals with severe sleep apnea indicated that waist circumference of 116 centimeters result in 91.3% accuracy of diagnosing male population of having sleep apnea, while in female, a waist circumference of 126.5% result in 95 accuracy in identification of respiratory sleep disorder in women. Direct or indirectly, the waist measures, either by waist circumference of waist to hip ratio, was associated to mild, moderate, severe, and moderate severe models in men and in women. Another aspect that must be taken into account is the hormonal difference between men and women. The role of sex hormones play a key role in sleep disorder breathing. Testosterone is implicated in obstructive sleep apnea and breathing control due to the higher obstructive sleep apnea prevalence and low levels of testosterone in middle-aged men. This study here examined the sleep patterns of individuals with sleep complaints and observed that men feel sleepier than women. The main difference found in polysomnography between these different sexes was that women have a significantly higher sleep latency than men, as well as longer latency for REM sleep. Men spend more time in stages 1 and 2 of non-REM than women, whereas women spend more time in deep sleep stages, phase 3. With this, it can be concluded that there is a difference in anthropometric parameters, sleep patterns, and respiratory variables of sleep between men and women. However, polysomnography data did not reveal significant differences in sleep efficiency between the genders. Sleep apnea therapies have been assessed by adult population, although the literature lacks studies examining potential sex differences. For example, CPAP treatment significantly improved functional status and revealed symptoms for both genders. The magnitude of improvement of each clinical outcome did not vary between sexes. The next therapy is hormone replacement therapy. Early community-based observational study reported a protective effect of hormonal therapy on sleep disorder breathing prevalence, but this could possibly be explained by a healthier user effect. Interventional studies of the effect of hormonal therapy on sleep disorder breathing are very few, with only a few randomized placebo-controlled studies exist, often performed on small samples of women without clinical significant sleep disorder breathing. It can be concluded that there is no evidence that female sex hormone changes during menopause per se are able to explain the increase in sleep disorder breathing in middle women, and conclusion of the effect of hormonal therapy on sleep disorder breathing cannot be drawn from the different literature. As the literature also shows, it can be observed that mandibular repositioning split are most effective in mild and moderate sleep apnea, but not severe obstructive sleep apnea. Treatment that has been associated with factors such as female gender, younger age, supine-dependent obstructive sleep apnea, lower BMI, smaller neck circumference, and craniofacial factors, however, are really validated method for prediction in clinical setting has yet to be established. Another very well established treatment is hypoglossal nerve stimulation. It is novel therapy in treating moderate and severe degree of OSA in patients who cannot tolerate CPAP treatment. Hypoglossal nerve stimulation is a novel alternative therapy for moderate and severe obstructive sleep apnea. Adherence of all these devices is superior to CPAP that has been speculated in some studies. However, more developments are needed to ensure the highest safety profile. Lifestyle changes is something very consolidated in the literature. Habit change strategies have positive impact of sleep disturbance and has to be encouraged. A major problem in the treatment of sleep disorder breathing is the adherence. Overall adherence for CPAP therapy according to several criteria was 72.6%. Adherence varied significantly by age and sex, ranging from 51.3% in 18 up to 30 years old women to 80.6% in 71 to 80 years old men. Younger patients showed peak CPAP use at the second night, but experienced a subsequent decline, including a higher rate of CPAP disuse among the youngest group. In contrast, older patients steadily increased CPAP use over time, taking more than a week to reach maximal usage, and demonstrated a slower decline in use. The proportion of patients meeting this criteria for long-term CPAP coverage by age group, plotted separately for men and women, can be seen in this figure. Percentage of nights where CPAP was not used over the first 90 days per day and the week plotted by age and stratified by sex can be seen in these two graphs. Specific challenges related to CPAP use, such as claustrophobia, may be more common in women than in men. Another possibility is that symptoms more commonly associated with OSA in women, such as insomnia and fatigue, maybe turn them less responsive to CPAP therapy, preventing the positive feedback from symptoms resolution. Finally, this study found that not using CPAP during the week can have a negative effect on patients' lives. Results displayed are model estimate accounting for within subject clusters, and these figures show the relevance of studies with this protocol design. Consequences of non-adherence to treatment. Non-adherence to CPAP is associated with increased 30-day all-causes and cardiovascular cause readmission in patients with OSA. Ensuring that CPAP adherence is crucial in addressing general and cardiovascular-related healthcare utilization and morbidity in patients with OSA has been studied. 30 days all-cause readmission rate was significantly higher than in non-adherent group. According to this Cochrane study, it was shown that there are many factors associated with adherence to treatment. In CPAP-naive patients with severe OSA, poor quality evidence indicated that supportive intervention that encourage patients to continue using their CPAP machines increased use compared with usual care. Moderate quality evidence indicated that a short-term educational intervention resulted in a modest increase in CPAP use. Low-quality evidence pointed that behavioral therapy led to a large increase of CPAP machine use. The impact of enhanced CPAP use in daytime sleepiness, quality of life, long-term cardiovascular risks remain unclear. Finally, there is a marked difference between sexes in relation to observed sleep disturbance, especially sleep apnea, which is more prevalent in men compared to women. An explanation for this prevalence may be related to female sex hormones presenting a protective factor. However, during menopause, we observed an increase in the prevalence of sleep apnea in women. The lack of overall adherence can be a public health problem due to the worsening of cardiovascular conditions and the effect of quality of life. Therefore, treatment strategies to help with adherence to treatment should be encouraged. Dona Ciência was created to disseminate science to children and adolescents. The purpose of this series of comics is to present in a playful and simplified way the various themes and topics of science, its concepts and discoveries. Importance of sleep, girls and women scientists, basic research, coronavirus, and astronomy are some of the examples of topics addressed by these collections. In the issue 41, as you can see here, we talk about the positive pressure devices called CPAP. So I would like all of you to visit this Dona Ciência webpage at Instagram, Facebook, YouTube, and TikTok. This lady explained about science in very fascinating and passionate way. And finally, I would like to thank my forever mentor, Sergio Tufik, and all my students, trainees, and technicians who have contributed for our studies over the years. I would like to also recognize the organization of this Congress here, and especially all of you for your attention, and hope see you soon next time. Thank you very much.